Buenos días. Mi nombre es Raimundo Pérez Hernández y soy el director general de la Fundación Ramón Areces, en nombre de cuyo patronato les doy a todos la más calurosa bienvenida, tanto a los asistentes presenciales como a los que nos siguen en streaming a través de nuestro canal. Muchos agradecimientos, uno muy especial a los panelistas por su participación en esta mesa redonda. Un saludo muy especial a Leire Pajín por elegir a la Fundación Ramón Areces para la celebración de la segunda sesión de esta jornada sobre preparación y respuesta en la era de las crisis sistémicas de medio ambiente y salud. Un saludo también muy especial a Raquel Lloti, amiga y colaboradora casi regular de la Fundación, secretaria general de Investigación del Ministerio de Ciencia e Innovación, y a Juan Fernando Muñoz Montalvo, secretario general de Salud Digital, Información e Innovación del Sistema Nacional de Salud. Last but not least, Tony Plasencia, buen amigo de esta casa, director general de España ISGlobal, con quien tenemos contubernios y conspiraciones regulares. Por supuesto, no me olvido de Gonzalo Fanjul, director de análisis de ISGlobal, que ha sido un poco el alma y el cuerpo de la organización de esta reunión. La Fundación Ramón Areces mantiene una más que fructífera colaboración con ISGlobal desde hace muchos años. En abril organizamos conjuntamente en este mismo auditorio la jornada sobre malaria, investigación con impacto en los tiempos del COVID-19. La pregunta ahora es, ¿estamos preparados para la siguiente pandemia? Esa es una de las interrogantes a las que van a intentar dar respuesta hoy los participantes. Está claro que necesitamos estar mucho mejor preparados frente a futuras crisis sanitarias. Esta es la lección clave que nos ha dejado la COVID-19 y que ya aprendimos de accidentes nucleares como el de Chernobyl y el de Fukushima también. Recordamos también la reciente erupción del volcán Cumbre Vieja en la isla de Palma, que podría haber tenido muchísimas peores consecuencias de las que desgraciadamente ha tenido. Hicimos unas jornadas de homenaje a los palmeños. Es necesario también hacer frente a esa impresión de vulnerabilidad y de indefensión ante posibles catástrofes que puedan ocurrir, tales como un tsunami u otra pandemia sanitaria, etc. Lo que antes uno no se atrevía a pensar, ahora resulta que puede ocurrir y que al fin y al cabo todo es posible. De aquí la grandísima utilidad del ejercicio de hoy. La reciente pandemia ha puesto de manifiesto la fragmentación de la gobernanza mundial en materia de preparación y respuesta a las emergencias sanitarias y el papel fundamental que pueden y deben desempeñar la ciencia, la investigación y la innovación para tener un mundo mejor preparado para futuras crisis sanitarias. Acogemos esta mesa redonda de alto nivel que ISGlobal organiza para contribuir y avanzar en este debate fundamental. Muchísima suerte en los trabajos y tiene la palabra la señora Elisabeth Cardis, directora científica del programa de radiación de ISGlobal. Muchas gracias.
Buenos días y muchas gracias. And thank you, all of you, for being here today. As you know, public health and environmental crises require rapid and flexible responses based on the best scientific and technological knowledge available. And for this, we think it's necessary to establish the scientific evidence base by drawing upon existing evidence at the global level, by generating new knowledge specific to the scientific and policy challenges posed by these crises, by promoting it to public decision-making authorities, thus improving the effectiveness and the acceptability of the response, and strengthening public-private alliances and innovative instruments that can contribute relevant or complementary elements to existing crisis response agencies, including the WHO, international and European centers, the Instituto Carlos III here, in the field of health and safety. So at ISGlobal, building upon the years of experience we had in preparedness and response work in relation to nuclear accidents in Chernobyl and Fukushima in particular, and all of the work that so many of us did together with our partners everywhere in the last more than 2 years since the beginning of the COVID pandemic, we have coined the term PR3, so preparedness, response, recovery, and resilience, to describe a system that combines all of these aspects within an all-hazards approach. It's a sophisticated machinery of policy, research, education, communication, and practice that we think is critical both during and following public health and environmental crises. And we've learned that very clearly in the last 2 years with the COVID pandemic. So it's in this context that Gonzalo and I, with our other colleagues at ISGlobal, organized the workshop yesterday and today with 3 objectives. 1, to draw the lessons related to PR3 from different complementary environmental and public health crises. 2, discuss how best to incorporate them in a future all-hazards preparedness plan at the global, regional, country, and local levels. And today, particularly, address the political challenges of PR3 through a conversation with high-level decision makers. So you might wonder why ISGlobal wants to play a role in this. We believe that we have a unique blend of expertise which spans from research to policy, and that uniquely positions us to engage both in research and in policy development for crisis preparedness, response, recovery, and resilience. In particular, the research we do covers most of the disciplines that are essential to PR3, including infectious disease and environmental epidemiology, health systems, climate, social sciences, and humanities, among others. And our scientists have experience from previous public health crises. And the tools that we use to tackle a variety of health issues in our extensive network of collaborators at all levels are key for PR3 research. And of course, we have extensive experience in different areas of research. Yesterday in Barcelona, we had the privilege to gather a group of 23 scientists and institutional expert speakers, plus a highly interested audience, to discuss the best way to prepare ourselves for an era of systemic environmental and health crises. And between the participants who were present and those who were online, the workshop brought together over 100 persons from 3 continents, Europe, Africa, and America, both North and South. And what we learned in this workshop reaffirms our beliefs. The world has the opportunity now to learn some hard lessons from COVID-19 and from other existing and past health crises, including the Chernobyl and the Fukushima accidents, the 9/11 crisis in the United States, and the increasing consequences of climate change, as well as the consequences of war and refugee movements. And we think that this needs to happen now, when there's a temporary window of political opportunity emerging from the global trauma of the pandemic. Yesterday, just to summarize briefly, in the first thematic session, we covered PR3 strategies related to different types of health crises, to infectious diseases, in particular pandemics, chemical, radiological, and natural disasters, including volcanoes, and including those arising from climate change, and also crises related to war and refugee movements. And with a strong focus on science, this session clearly indicated that the difficulties and the challenges that have been encountered in all of these, and the needs for preparedness, for response, for recovery, and for building resilience are shared between all types of crises. In fact, we had the same message coming from all of the speakers. It was very, very interesting. So really this strengthens our belief that we need to develop an all-hazards approach and to learn from each other. And there was a clear willingness of all the participants to do this. The second session, which is the institutional session, brought together representatives from global, European, national, regional, and local institutions, including some represented here today, in particular the African CDC, with Dr. Wessam Mankula, who's sharing this table here. And all of them shared their experience and their preparedness plans and/or activities. And so on the basis of the discussions yesterday, we've identified a number of following needs which we hope will be important for you in your discussion. First, we need a comprehensive, risk-based, all-hazards approach based on a multi-sectorial and multidisciplinary collaboration with preeminence of health systems and public health and epidemiological intelligence to create insight and to guide action. We also need an all-inclusive, people and community-centered approach with a strong connection with local health institutions and scientific endeavors, and we think that local leadership here is very important. Another point which I think is really, really important is that we can't learn if we don't evaluate, and we can't succeed unless we avoid the temptation to move from one crisis to another. We need a sustainable model which should include a peacetime phase, a time between crises to adjust our protocols and to adjust our plans rather than simply to jump from one to another in an emergency situation. And finally, we saw quite clearly yesterday, particularly in the institutional session, that we are threatened by hyper-fragmentation of actors and responses. And in fact, it was really very nice to see that Africa shows that more integrated models are possible. So I'm at your disposal for any question you might have about the workshops yesterday. Otherwise, very much happy to be here and to hear the results of the discussions. Thank you.
Thank you so much, Elizabeth.
Good, well, very good. Good morning. My name is Gonzalo Fanjul. I'm Director of Policy Analysis at ISGlobal. In September 19, the first report of the Protection Board, World Protection Board, which is an initiative of the World Bank and the WHO, said, "It is true that the past is the prologue of the future. If that is true, we are facing a true threat of a very lethal pandemic." That was September 2019. The world needs to proactively set up the systems and commitments that are necessary in order to detect and control epidemiological problems. This preparedness is a world common good. 2 years later, 2.5 years later, 20 million people have died. If we look at the estimates of the excess death or mortality during the pandemic. And I think that a good part of the international community would have liked to pay more attention to this report and many other reports before this one. Each person here on this panel probably thought something similar to what is expressed in this report long before COVID. Each of them has devoted the last 2 years or 2.5 years every effort to combat this pandemic, offer responses scientifically, institutionally, politically, from the point of view of programs to try and soften the human and economic impact of the pandemic. And of the many things that we've learned, I think there's one that goes that is most important. Good preparedness and response systems, the ability to get ahead of problems and respond in the short term and act in a better organized way than we have done in the past, saves millions of lives, but also prevents socio-economic shocks whose consequences, geopolitical and political consequences, are deeper than we can imagine. Philanthropist Bill Gates, in a book that's going to be published this week titled How to Prevent a Pandemic, says that a good vigilance and reaction system that is oriented at stopping a pandemic within the first 100 days would have saved humanity 98% of the deaths caused by COVID-19. This is a statement by Bill Gates. And as Elizabeth has said, and ISGlobal tries to say with its PR3 model, infectious diseases are one of the risks we're facing. When we talk about systemic risks to health, we're talking about a range of problems that include many common elements, but at the same time are completely different. And I think there are fewer debates that are more important than this one. right now, and that is what we're going to do. Give you the opportunity to travel in time, go back to the first half of 2019, the few months before the pandemic, and ask ourselves what we would have done differently, because we're in the years before the next systemic health crisis. So it's key for us to learn the lessons that we have learned in such a harsh way in the past 2 years in order to have much more efficient and sophisticated response models. So we're going to ask ourselves about the what models we need, what strategies we need, but also the how, what tools we need, what institutions, what financial mechanisms, what standards, what legal framework do we need to set up this prevention and response system. This is a room where this type of meeting are not as massive as they used to be, but there are more than 550 people registered for this event. A lot of them, I'm sure, are following us online and will continue to do so. So we're speaking to an audience. We're part of a conversation that is much wider and more extensive than this room. And it's a conversation that the institutions represented here have started. I'm going to introduce the speakers this morning, and then we'll have a dialogue. First of all, Raquel Yotti, she's General Secretary for Research at the Ministry for Science and Innovation. Juan Fernando Muñoz Montalvo, General Secretary for Digital Health, Information and Innovation at the National Health System of Spain. Isabel de la Mata, who's main advisor of the EU Commission in matters of health and crisis management. Dr. Vesem Mankula, Director of the Center of Emergency Operations, African Center for Disease Control. Bernard Pekul on my left, Executive Director of the Drugs for Neglected Diseases Initiative. Oliver Morgan, Director for Global Health, Surveillance and Risk Assessment of Health Emergencies at the WHO Hub for Pandemic and Epidemic Intelligence. On his right, Anja Langenbucher, Director for Europe of the Bill and Melinda Gates Foundation. Françoise Vanny, Director of Foreign Relations and Communications of the World Fund for Combating AIDS, Tuberculosis and Malaria. And Antonia Placencia, Executive Director at ISGlobal. Good. To manage this is like a is like managing a circus with many different events going on at the same time. We're going to have a couple of rounds of questions with the possibility of being flexible and allowing people to sort of interrupt each other, and then we'll have the opportunity of hearing some questions from the audience. My first question is for you, Raquel, is for you. And it has to do with the abilities, capacities of your ministry. Of all this, we're talking about the new model of preparedness and responses. How much of this depends on the basic competencies of the Ministry for Science and Innovation? Why should we commit ourselves to these areas as strategic elements of whatever we prepare for the future? Why? Well, thank you very much for that question. I think that to start, we should speak of innovation in terms of being prepared for crises. It's very important, innovation, because it should be indivisibly part of any system of response. And this is something we talk about of lessons learnt, but in many cases they're not lessons learnt. We already knew these things, and the pandemic has just reminded us. We knew, and we had the structures, and we do have them currently. Structures like the Carlos III Health Institute that depends organically on the Ministry for Science and Innovation, but also functionally depends on the Health Ministry for Health. It's a bridge, and this is not just symbolic, that bridge between science and health, but also operationally was designed with a clear mission, and that is the knowledge that is generated should be used and leveraged to design public health policies. The Carlos III Health Institute plays many different roles, which in other countries of Europe are distributed among different agencies. On the one hand, it is a public agency of research. It does research. It is also it finances research of all research within public health and health in general in Spain. But in addition to that, it is a public health institute, and it is an advisory agency, technically and scientifically. At the Ministry for Science and Innovation, we have other structures. We have structures. One of the things we identified during the pandemic was how things are fragmented. We have a public research agency, which is the largest in the country, the CSIC, which is known beyond our borders. And during the pandemic, it developed a platform for global health in response to the pandemic, in reaction to the pandemic. The capabilities that were identified at the time and which were deployed were very interesting. But what we identified was a need for integration and integration with other structures, other capabilities, which traditionally had worked in collaboration, but not on the basis of the planning and the structure that we needed and will need in the future to address future pandemics. So we do have the capabilities, we do have the structures, we do have the institutions. What we need, first of all, is money, financing. We've got to be aware that the future is at stake, and for too long we'd forgotten that. These structures that already existed had been under-financed and weren't really taken care of properly. And we need also not just financing of each of the structures, but integration through planning, the proper planning that goes beyond the institutions and that incorporates at national and international level those capabilities that we have. And thirdly, and the Secretary General for Digital Health, I'm sure, will go into this too, the concept of researching global health and its association with data. That is becoming a different thing. It's becoming enormous. We knew about this, but it is becoming hugely important in such a way that research associated to the generation of data and exploitation of data or data harvesting within global health and within public health is absolutely key. And in that respect, the collaboration with the Ministry for Science and the Councils for Health in all the regions of Spain is important. We have to have close collaboration where researchers that have the knowledge can share, can participate, and can share data in order to act quickly and flexibly in order to combat health problems. We had an experience that transformed the way we understood collaboration and what we could do by creating synergies, and that was the National Study of Epidemiology, which is a very good pillar to build upon now in the future. Thank you, Rachel. You've been on the other side of the fence too. You not only have been an administrator, you have also been administrated by others. Do you think that the scientific community feels that it is more supported now than it was before the crisis? I think so, but I'm not sure whether this will last. After a pandemic, after a crisis, at a time of tremendous uncertainty, social mobilization, not just in Spain, but globally, everything was done. But what we need now are financing measures, specific measures. We're working on a new science law or act, and that should move into the future. So this is not just a temporary thing. Thank you, Rachel. Juan Fernando, I'll continue with you. The Health Ministry, has been at war. I think You're still in the trenches right now throughout this pandemic, and what I want to ask you is that the way you understand preparedness has changed. What would you do now differently from what you did in the past?
Thank you very much for this question. Thank you to the organization as well, and the very beautiful venue where this conversation is taking place, as you said before. The elements that the pandemic has had an impact on are very important. There are many structural elements. We have the creation of the future State Center of Public Health with the vision of being a governance point, intersectorial site, as you have pointed out yesterday as well. There are preparation elements, preparedness elements, as is the strategic reserve and all the coordination at the European and Spanish level of the necessary elements, the independency from Europe as to the industrial capacity, the scientific capability as well, and the capability of action, where we have to be working on, and of course, legal issues, etc. They have been quite well collected in the commission that was built for the reconstruction at the Congress. If you allow me, I'm going to focus on two elements that are more unknown, more close to my own personal experience during the 2 years and a half, the trench. First of all, as Raquel said, it's critical, the use of data. The use of data for the decision-making. And we have been this whole century saying that the data are the new oil of our society, but nevertheless a pandemic had to arrive, a global pandemic had to appear, so for us to realize that without the data we couldn't face it, we couldn't have faced it, as we have been able to do. Adequate quality data, and we didn't have them. The reality is that we didn't have them. From the ministry, not only our own, but also sciences, autonomous communities and other ministries, and many other organizations, we have done a cooperative work and a constant work in order to palliate all this. And I would like to reflect upon the main landmarks, because if we want to learn something from what has happened, and if we want to make all those changes, I think the essential thing is to see where we have been, what we have been going through. In March 2020, we had to set up rapidly something to make a full complementary follow-up to the system we already have. We didn't know the impact that the pandemic was having on our health system. That was a key element. We had a daily healthcare capability and a system that allows us to have a normalized, standardized information and on real time of all the tests that were carried out in this country, complementary to all those already existing, that allowed to do greater epidemiological and scientific follow-up. This was an important challenge because without them we were absolutely blind and at a loss in the global system as to the global impact. We didn't have the fragmentation that we're talking about, and that is very important. And the real time was missing in view of such burden that we had in front of us. After April, we had to work together with Raquel, who was directing together with Faustino Blanco the epidemiological study, because we were blind as to the impact of the first wave. We needed scientific knowledge, and we needed that for that impact, that economic shock that came about, because we had de-escalation, and we needed to de-escalate in order to have something with what to work with in the next element. This was an enormous effort, 90,000 people to interview and 4 weeks to prepare that. Without an information system, we had 3 shifts of 8 hours to be able to really organize all that in the midst of the confinement in order to obtain that knowledge. We were the first country of doing such a big thing, but in July we had another challenge. We had to open the countries to one of our essential elements, not only controlling the health systems, not only decide the impact that it was having and have a scientific knowledge to face that, but we also had to manage the country in the midst of a pandemic. We had to have the system Spain Travel Health in order to be able to manage the risk that went on, and then be prepared for vaccination, for a solution that yet didn't exist, not only as an information system that could put together all this data, but also with a modeling that allowed us to make decisions on those data. Without that modeling, we couldn't speak with the whole territory, nor in the purchasing with Europe, nor downwards as to the territory, because every element has to be who had to adjust to that response. And finally, the digital COVID certificates managed from the European Commission itself. It took us weeks to do that since it was approved in the regulation and put them at the level of the countries without a critical tool to do that. And this needed to have data. The second element is how we worked. This has been mentioned by Raquel as well. This is something different in the administrations have a hierarchy, and this needed multi-level cooperation, absolutely collaboration. This is a sudden change and very important change in these organizations, and this we have to learn and internalize. And in order to conclude one lesson, I think that the vaccination in Spain is a success case, and it's an example of a success because it really means the trust of the Spanish society in its public health system, in the professionals, and especially so in primary care. And this is a lesson that we have to learn if we want to be prepared for another pandemic. And I believe that this is something that time and the closeness of primary care has been what has allowed us to reach those vaccination quota without face masks and seeing our faces here today. Fascinating and very complicated, the responsibility of use this time for somebody as you who is responsible for managing data. In the seminar yesterday in Barcelona today, we talked about citizen science and how we started to create the knowledge in a different manner than we did before. And I think that this is the good oil of the 20th century. We're going to close this first part, institutional part, with Isabel de la Mata. Isabel, who works in the European Commission. And the question is very simple. How has this influenced on the structures and the plans of the European Union in issues of preparedness and response? Could you talk to us about the new era, the new organization, and other initiatives that are being prepared by the European Union? As my colleagues, I would like to thank the organization for organizing this event that is very important and for thinking about the European Commission and invite us to participate. The Commission had already several structures for the coordination of a crisis and also the Council. This allowed us to activate very rapidly once the crisis started, and in February 2020, we were already at a cruise speed with the political response mechanism and with the Committee of Coordination of Crisis from the Commission. What has changed is that first it has allowed us, the General Direction of Health, to be there. We had been discussing for a certain time about the safety policy of the European Union, and every time we discussed, I said, and health. And it was very hard to have the support of all the colleagues. Of course, now it is quite clear that health is a part of the safety of the European Union. And then we also had our surveillance and response mechanism, the surveillance and response mechanism, early response, that is based on the CDC. But what we have done has to strengthen all these mechanisms and the creation of two mainly new ones. One is the EGHRA, the authority in preparedness and response to emergencies. Normally, as it is not in the acronym, the P of preparedness is obviated, but it's one of the most important ones. Without preparedness, we can't have any response, obviously. Another mechanism that has been created is the Executive Agency of Digital Health. In reality, it has been reformed. Before we had a first agency that is enormous. Part of the importance that this crisis has made us see, for us politicians and the citizens, the role of health as a generator of problems in other areas, and that really requires a comprehensive view is the health program, the new EU for Health that has a budget of 5.3 billion. We have to bear in mind the previous program had much less. It has been multiplied by 12 now. When in Easter 2020 we received the call, what do you think if we give you 9,000 million? The figure that was managed at that time for the health program, it was like a shock. And that is the call that we all want to receive. Well, I received on at 9 o'clock, at 11 at night. It was everybody was mobilized, and we started discussing and debating. We were absolutely delighted. But it's not only an issue of money. Well, this of course has allowed us to be prepared with respect to the scientific community, the health community in general, and the general direction of health was the poor direction nobody paid attention to, because we had to be with the research direction. That was the one that had the money. But we went beyond this research direction, and we started being important again. But it's not only an issue of money, it's of organization. It has allowed us to launch as well in November 2020 the whole new legislative process that not only EGHRIN is part of, but also the CDC, the drug agency, and the mechanism of border threats for health. Now we are already closing, I hope, the new regulations of trans-border threats for health, and we've gone to the highest level. And this will allow the mechanism that did already exist, the Health Safety Committee, but that had a consultative role, now have a more relevant role. The CDC acquires more actions, and the EMA more functions for things where it wasn't there, for drugs and health products, and the managing of stocks and deficits. Until this pandemic, the drugs were approved, and then nobody did really the follow-up. There was not at the European level any entity that was responsible for that, but now it will be the EMA that will deal with that. The FDC as well did assessments and advisory objectives, but it could be left there as a document that then was published. But now it has a much more greater value, and we have to follow the indications that will be given. So this has been reinforced. This has also allowed for the countries, this has allowed them to see that it's better to go together than everyone doing its own thing. This has allowed us to buy vaccines and tests, accelerate the production of some drugs. Then they were not that efficient or effective, but it has allowed us to implement the mechanism where EGHRIN has to take part. EGHRIN, for the expectation not to be superior to reality, is not an agency. It's a general direction of the Commission as all the others. It has an important role, yes, in the two parts, in the preparedness and response. It has to be in touch with the companies, pharmaceutical companies and others, to be prepared as soon as we have to have additional production, and we ourselves need to coordinate much more with them. Until now, now we are learning who deals with what. The vaccines, they do that. The vaccination, we do it. Well, this is a process that is very recent because they started working on the 1st of January with a very important budget as well. That depends on the one side on the health program and also research program and others. Yes, you have an experience that is really privileged of having been in different institutions. Do you have the feeling that this political window of opportunities is going to be maintained with time, or that the war, the inflation, the next crisis are going to move away somehow this? Well, we have seen that we have stopped talking about COVID to stop talking about Ukraine. And now I dealt with COVID and now much more of Ukraine than COVID. Yes, the new crisis is shifting the previous one, but it's a true opportunity nevertheless. And I think that the conference of the European Union, where they are going to decide what European Union do want to have, where we want to be heading to. We lost the opportunity when we discussed in Lisbon to give more health competencies. Now we have this opportunity again. We have seen that the voluntary coordination is working, but that sometimes we need mechanisms that are more important. And although you laugh, Fernando, you know very well that the animal health and food health, where there is the strong legislation, those crises are cut down more rapidly because we have a possibility of having an immediate response.
Let's move now after this institutional block, let's move to other organizations that are maybe, although it's impossible because every institution is working everywhere, but more on the scientific sides. And Wessam, yesterday we had really the privilege to listen to you, to listen to the experience of Africa in this regard. I must say that this is a story that must be told more and more in our context. But I would like to ask you today to do like the snapshot of what you told us yesterday and try to share with us the two main lessons that you think that the Africa CDC have learned out of this pandemic and how has changed your work and your position in the African context.
Thank you so much, Gonzalo, and thank you for ISGlobal and Ramón Areces Foundation for inviting for this important discussion. I think it's timely to discuss the lesson learned from COVID-19 and how to build on those lessons learned for dealing with future pandemic. Let me select two of the main lessons that we learned at the Africa CDC from this pandemic. The first one that COVID-19 reiterate is infectious disease are a whole of society issue. It's not a problem for health sector. Yes, we have impact on health. Unfortunately, we lost more than 6 million people during the course of COVID-19 globally. More than 500 million people got the disease. There is a pressure on health system, but this is not the whole story. The story going beyond the loss of lives. It's going to affect our livelihood. It's going to affect our economies. Some estimations say $16 trillion losses in economy because of COVID-19. Impact on educational system as well. Impact on stability and security. So we need to have a holistic overview about infectious disease and how to deal with it, to be having multi-sectoral, multilateral approach to deal with infectious disease and their threat. So the way forward for us from this first lesson, bringing this agenda of health problem at the top level of leadership, as Isabella mentioned. This is the timely opportunity for us to bring the health challenges at the agenda of the leadership. And this is what we did as Africa CDC. At the beginning of COVID-19, we established what is called AFCOR. AFCOR is Africa Task Force for COVID-19. And this is a structure for coordination, collaboration, and communication between the member states. This is coordination structure within African Union Commission. At the top of this structure, it's African Union Bureau, which is composed of representatives from heads of states. That our director of Africa CDC give bi-weekly briefing for them about the COVID-19 status and get their strategic guidance about how can we move as a continent in order to respond to this COVID-19. Under them, we have 3 ministerial committees, one for health, one for finance minister, one for transport minister. Then below them, we have technical advisory group. Then Africa CDC absorb all these recommendations and start implementing. So bringing the health challenges to the top of the agenda of the leadership and political leadership, this is a key part. And second issue is how our response in the future looks like. And this will be determined mainly about what kind of investment that we will be doing today in terms of preparedness. Some of studies mention if we are investing $5 per person per year in strengthening public health capacities like strengthening surveillance system and also pathogen genomic sequencing, in addition to public health emergency operation center, this will help us in the future to deal efficiently and effectively to the future pandemic. So this is the first lesson. Second one, I think we need to discuss openly the issue of globalism versus regionalism. And this is one of the key issues and one of the key challenges that we face during the course of this pandemic. I remember starting from early at the beginning of this pandemic. Getting access to masks, infection prevention control supplies, test kits, and recently access to COVID-19 vaccine was a big issue. Even if you have the financial resources, also you have limited access to these critical commodities that will enable you to respond effectively and efficiently to COVID-19. Some of countries block what they have, and some of countries, when COVID-19 vaccine become available, they insisted on nationalism. They start offering the vaccine when they already settle their people and providing the vaccine to their people. So this need us to revise again globalism versus regionalism. And this is why one of the driving agenda that will take in the coming period, what we call new public health order in Africa. And this will be driven by four main things. The first one, strengthening Africa CDC and national public health institutes, strengthening their capacity in order to respond to different public health emergency. And second part, strengthening local and regional manufacturing capacity in the continent. And this is very important, not only to have manufacturing capacity for COVID-19 vaccine, but also for diagnostics, for infection prevention, control supplies. Third part, workforce development, investing in workforce development within your country, within your region. Because sometimes waiting for international support, especially in the era of epidemic, may take longer time. And finally, partnership. And this partnership should be based on mutual respect, based on that we understand our context. Then when you come to support us, you need to understand this context as well. Thank you.
Wessam, if you had to put in order money, political will, and coordination, institutional coordination, how would you order those? What do you think the Africa CDC needs most now?
So I think currently we have this political will, and we managed during the time of COVID-19 to push this forward at the top level of the leadership within African Union Commission. What we need currently more financial resources, and yes, to push this agenda forward in the continent. Thank you.
To Bernard, because it's really interesting. Wessam has been talking about the risk of neglected regions and neglected populations, and that is precisely the purpose of DNDi, trying to deal with neglected diseases, which means neglected patients. No? And my question to you, Bernard, is very similar to the one to Wessam. What have you learned? What has changed in your work, in your panorama, in the last period, and how do you envisage the future? No?
Muchas gracias. We all know that over the last 2 years, science has delivered remarkable and life-saving innovation at unprecedented speed, shortening clinical development and regulatory timelines, and quickly validating platform technology in a way that could be transformative for a large range of other diseases. But we also know, and no one can deny, that the fruits of this scientific progress have not been equitably shared in the case of vaccines. Today, while we have 80% of coverage in many countries, income countries, we have less than 15% in low-income countries. And history is currently repeating itself when it comes to access to therapeutic. For example, the novel antiviral like Pfizer, Paxlovid, is in the same situation as vaccines. These two realities are the fundamental lesson of this pandemic. Science can triumph with sufficient political, financial, and scientific resources, but equity and access will never be realized without serious and systemic change. And sadly, many of the challenges identified in relation to R&D and access to vaccines, therapeutic, and diagnosis for COVID-19 are acute examples of the chronic failure in a global health innovation system that DNDi and partners have faced and attempted to overcome over the last 2 decades. Without a dramatic shift in approach, poor and neglected communities, people in low and middle-income countries, and those on the margin of the society will continue to be left to fend for themselves, struggling for access to new treatment, vaccines, and other health tools, disease by disease, product by product, country by country, company by company. At the NDI, we noticed right away in April 2020 that there was little to no commitment of global health funders and actors to prioritizing and financing research in low and middle income countries. So we helped to launch and have hosted the COVID-19 Research Coalition, made up primarily of researchers in low and middle income countries. We are coordinating today Anticov, a multi-country adaptive platform trial conducted in 13 African countries with 26 partners from Africa and global partners to identify new treatment for mild to moderate COVID-19 outpatients. Soon we will extend this network to Brazil and India. We have collaborated with ACTA as well as various research consortiums to select a new therapeutic. And now we lead an open science consortium known as the COVID Moonshot to identify novel early-stage discovery projects to contribute to building the pipeline for new treatment for COVID-19, but also for other viruses and other pathogens of pandemic potential. We also notice that while the discourse of wealthy government, who spoke of global solidarity and of life-saving health tools as global public goods, sounded nice, the global architecture that emerged in early days of the pandemic came with serious power imbalance that determined who will have a seat at the priority setting and decision-making table in a global COVID-19 response. And we knew already from last 2 decades of our own experience as an R&D organization focused on addressing the R&D needs of the most neglected community, that the lack of coordination and globally agreed rules throughout the R&D process, rules that will ensure transparency, open sharing of knowledge and data, appropriate management of intellectual property, transfer of technology to ensure sufficient global manufacturing capacity and affordability of any new health tools would inevitably lead to inequitable access. So consequently, we have advocated for the kind of systematic change that will address the challenge once and for all.
So let me ask you about that. When I saw President Biden and the American government supporting the patent waiver, I thought I had seen it all. That was, I could. Actually, President Sanchez supported the patent waiver as well, was one of the few. And we could discuss for hours about whether that was the proper solution for what we needed at that time and what we need. But it showed that something tectonic was changing, that at least for a time. Is this true, or this is just artificial? Do you think that we are actually in the sake of changing something?
Well, definitively, this crisis has produced some change, but many declarations have been a sort of mirage. Right. So there have been a strong statement without translation into something that could concretely change the dynamic of access and transfer of technology. Right. So I think we need more.
Okay, very well. That's fair. Oliver, this is a surprise because I told you I would go for you, but actually later I thought that it'd be great to hear you now. The WHO Hub for Pandemic and Epidemic Intelligence is actually one of the best news that we've had during this process. And I was thinking when I read, I didn't have the chance to read the Gates book yet, but the excerpt that he does, and he talks about this idea of creating a group of 3,000 experts under the WHO. It would be, and actually I thought, well, this is Oliver and friends expanded in the, but can you tell us about this new hub and what it means, both for the international arena and for the preparedness for next crisis?
Sure, great. Thank you very much. It's really a pleasure to be here. The WHO works in health emergencies really across the spectrum, the goal to support this member states or countries. Oh, thank you very much. To support countries around the world and communities both to prepare, to detect new health emergencies as they occur and respond to those. And I joined WHO in 2016 after really an existential crisis for the organization at that time, which was the outbreak of Ebola in West Africa and the many real and perceived failings of WHO really posed some major challenges again to the global health architecture for health security. There were several elements to the response to that crisis, and one was the creation of a new health emergencies program, which is currently led by Mike Ryan. And within that, there was the need to really detect, assess risks, and communicate those in a much better way. And we've been working at that very hard over the last 6 years with some success. We have 7 teams actually in different geographic locations that provide 24-hour coverage 7 days a week of the year to identify and assess different public health risks. We currently process about 9 million pieces of information each month, and we detect about 4,500 signals of events that as WHO we're worrying about as having potential epidemic or pandemic risks, and we also deal with chemical, radiological, and other types of disasters as well. We do about 300 investigations every month in different parts of the world where we, as WHO, step in. And of course, there are many other events where member states themselves or countries themselves are investigating without the intervention of WHO. But just like all of the other panel members, the pandemic really by far and away exceeded our capacities very quickly, even with the investments that we had made over the previous number of years. And we really had to set up our systems pretty much immediately as the pandemic started. I kind of definitely relates to what Juan Fernando was saying around having to create the systems as you go forwards. And we were putting together twice every day the information from 194 countries around the world, which was really very difficult for us. And we had a lot of support with other colleagues, such as the European CDC, actually, in the European region. And we've learned quite a lot from all of that experience. I think some of the critical things that we've learned is that actually, and Wessam talked about this, is that having the epidemiologic data is not enough. It is a whole of society. Outbreaks and infectious diseases in general are a whole of society challenge, and you need the data from different parts of society to understand the context in which the event is happening. And this is what we call public health intelligence or pandemic and epidemic intelligence. It's the combination of epidemiologic information with contextual information to make a complete understanding of risk. And so one of the big challenges we face doing this as a global community at the local level and the national level, regional and so on, is really pulling all of that information together. And Raquel, you spoke about the fragmentation of information systems, and that is true in every country, actually, and certainly true at the global level. And this is one of the challenges that the Pandemic Hub in Berlin is aiming to address. So as a response to some of these challenges that we faced, WHO has established a new entity, a new office in Berlin. It's part of the Health Emergencies Program and connected to WHO Geneva, but it has its own mission, and that mission is to really try and address some of the global systems issues that we face. So these include, how do you connect the different types of information? It's not exactly that we don't have enough information. Maybe it's we have too much information, and how do we connect it and make sense to it? And in public health, we're a little bit old-fashioned, let's say, in terms of how we use technology and apply technology, and I think we need a transformative effort to really join the fourth industrial revolution and apply modern data science approaches. In addition to that, we need to face the biggest challenge that we've all encountered during the pandemic and that we encounter in every outbreak, which is how do you turn the information that you do have into effective decisions? And we don't have an answer to that. It's a really complex issue. It's partly technical, it's partly political, but it is an issue that we all recognize and that we all need to address together.
Let me put you on the spot, Oliver. Do you agree with Gates? Do you think that you can stop, you can avoid 98% of the deaths if we are able to act decisively in the first 100 days of you agree?
So it's a little bit of a paradox around how the world addresses emergencies, especially large-scale humanitarian emergencies, where the resources scale up as the emergency increases. But when we're talking about infectious disease, you really want to invest as much resource as you can at the very beginning when the problem is at its smallest. And this is a political paradox as well, because we're asking, how do we invest that effort when there is no problem? But we've seen this, we see it currently in the Democratic Republic of the Congo, where there is a new Ebola outbreak, and the investment of effort at the beginning really, really does make a huge difference. So in principle, Mr. Gates is correct.
Yeah, I think that's a very good example. Okay, so we move to the final block in this first round. Annie, I want to begin with you, with institutions particularly focused on global health. The Gates Foundation is a strategic player, far beyond the funding that it provides, which is huge, but is really a strategic player. And I would like to understand, where do you see your role, the role of big philanthropic organizations that have been critical in shaping the global health panorama in the last couple of decades, in this discipline of preparedness and response in the PR3 that we are discussing today?
Yeah, thank you for being here. Thank you for having me. I think the foundation is, of course, a very, as you say, big player within the global health community. I think we should put it in perspective, though. In 2019, we're 41 billion spent on global health, and 6% is the foundation with 2.5 billion. So we still do rely very much on working with other partners. We rely on the WHO. We rely on all the other donors, such as Spain, to, of course, contribute to this effort on global health. I think the advantage of a philanthropic player like the foundation is to be able to be independent of political cycles and take risks. And so I think that has been, over all the years, one of the examples where we could be very catalytic, because we're a very specialized organization. So global health is, of course, by far the largest area of our investments. And so that makes it, of course, easier to be able to really focus on problems that we determine as the ones that have the highest burden of disease and the largest mortality rate, as we define it. And of course, to put our efforts both from the research and development to delivery, to access, to equitable access, which has been one of the biggest part of the debate here, really at the center of our attention. So I think our ability to, beyond different budget cycles, to actually continue as a long-term investor, so to say, spend, take risks that others cannot take, and drive innovation, in addition to probably by now the convening power and the political voice that we have, is an important one. I think achieving health equity, which was one of the points that came out here, has been always at really the focus of our attention. And I think this is one critical and vital part of the mandate that the foundation has. With regards to global health security, that is, of course, something that has been and become much more of a focus area going forward. And I think the biggest parts here, which also came up in the discussion, both on the domestic side and the global side, which is on the one hand side, of course, continues long-term investment in R&D. It is surveillance and tracking and finding out, and is, of course, above all and as an underlying baseline that we need and we have seen now as one of the critical parts is health system strengthening and a focus on primary health care. And I think these are the elements that we have seen, and if we look back to the Ebola outbreak where, again, we've seen some of the assets that have been created, for example, for polio in Nigeria have helped tracking that. We've seen with the creation of CEPI, the Coalition for Epidemic Preparedness and Innovation, as a direct response to the Ebola outbreak of the time. That was a positive. That was a positive thing that came out of a health crisis or a pandemic crisis. But at the same time, we have seen a neglect and also a step back on very important diseases, such as the one the Global Fund is tackling, TB, malaria, HIV, and we've seen sort of, funding at risk. We've seen also step backs with regards to tackling those diseases, which is something that, as we now step forward and try to address the pieces that the foundation, as it now looks at a pandemic preparedness strategy, wants to really keep in mind. How can we make sure, and that also came up in the discussion a lot already, that we think of that in a sort of coordinated, and comprehensive way. And I think coordination, prioritization, harmonization, these are all, and it sounds very nice, but I think this is really the key pieces that have led to, as we've now all heard, some of the breakdowns in the system and some of the victims that hopefully can be prevented going forward. I think money will, of course, be a challenge. Funding going forward, we've all heard that there's a lot of demands on the system. We have a war going on we're not at all far from here. And there will be on the European budget, on the national budget, on the, there will be a lot of demands. And I think the key will really be to prioritize very clearly what an effective pandemic preparedness strategy will look like. For the foundation, we've identified kind of 5 key things going forward, which you will also find in Mr. Gates's book that is, of course, coming out now. But it is on the one hand side, as I always think about it, almost like a baseline of R&D spending and sustainable finance for the space. It is then at the same time health system strengthening and the surveillance piece that we talked about, the tracking, the detecting. And then, as you've heard, that we are in coordination, but also thinking of the WHO as a key player here, this pandemic force system, which is, as Bill always says, the people that wake up in the morning and what they think about is how to prevent a pandemic.
Thank you, Anya. Do you perceive that the private sector is responding in a different way? That we are now witnessing really historical changes in some of the. But do you think that they are now more part of the solution than they were before?
I think we've seen, and we have an institution which is called the CEO Roundtable, where Bill Gates convenes sort of CEOs, and this is happening for many, many years. And at the beginning, it was used to very strategically put pressure on pharma companies to go down with prices on vaccines, but also drugs and therapeutics. And we've seen a tremendous change already. So we've seen willingness, we've seen the ability to actually share knowledge, to work together. So I think the reaction of the pharma industry, especially at the beginning of the pandemic, were very, very positive. I think anything can be improved, and we need to make sure that we continue with the pressure and with the political pressure now to make sure that they continue to feel the responsibility and also see the benefits, of course, for them. Yeah.
Well, certainly they've seen the risks, so I'm sure that they will see. Okay.
Françoise, I'll continue with you. Françoise, the World Fund for combating AIDS, TB, and malaria has played a very important role in combating disease in developing countries. How do you face this challenge? What's your perspective? How are you contributing to PR3? Well, thank you for the invitation. Thank you to ISGlobal and all the panelists. I'm delighted to be here. First, I'd like to say, as has been said before, we are facing many crises. And what these multiple crises remind us is that the vulnerable are the ones that suffer most. And that brings us to equity and solidarity. And I want to put those concepts at the top of the list because Equity and solidarity are the most important things at the World Fund. Second, this organization was created 20 years ago to combat the most lethal pandemics of the time, AIDS, TB, and malaria. And TB, in fact, is the greatest killer in the world after COVID. So our background is combating pandemics, saving lives, but also breaking through this cycle of pandemics. And in 20 years, thanks to the contributions of all the members, we've saved 44 million lives and reduced the combined rate of mortality by more than half from AIDS, TB, and malaria. How have we done that? And when we talk about preparedness, we have invested in health systems. It's been said before. We've invested in about a third of our resources in systems, contribute to combating these three pandemics, but also help us to help the countries respond to COVID. And these health systems can help people to be better prepared for future pandemics and crises that might happen. So that is our background and our approach. We focus a lot on health systems, inclusive, resilient health systems that can combat today's pandemics and the future's pandemics. And the impact of COVID-19 on our work has been quite significant. It has been, in fact, devastating, and we are responding very strongly in order to make sure that that negative impact does not continue to happen. But we must respond to all pandemics in a comprehensive way. You can't be fighting TB, then forget about TB, go to COVID, then forget about COVID and go to the next thing, which we don't know what it will be. It has to be comprehensive through inclusive systems, and that is key. And that is key. And in that respect, our response, the new COVID-19 pandemic, was very strong. We've invested more than $4 billion additional dollars from over and above what we usually invest in more than 120 countries to help them to mitigate the impact of COVID over and above AIDS, TB, and malaria, strengthen their health systems and combat COVID as such. So that's our background. We've been fighting pandemics for 20 years and adapting and scaling up within the context of the response to COVID. If we now come to how that contributes to preparedness in the face of future pandemics, well, investment in health systems. Health is not something you can manage from one day to the next. You've got to do it every day. We invest in very elements of health systems that are key. Staff, workers in the health field, workers, community workers that are first frontline workers, detection, monitoring, tracking, laboratories, supply chains, data, information management, all these elements and systems that we have strengthened in the last 20 years to fight AIDS, TB, and malaria are the same that have allowed us to respond to COVID and reduce its impact in general. And we have to continue to strengthen that in the future. Today, we are investing about $1.5 billion in strengthening health systems and these tools that I've just listed. And through that, we are contributing, obviously, to preparedness in the face of potential future pandemics or health emergencies. I've got a question similar to the other one about the private sector. Civil society, you have enormous experience with civil society, which is key to move forward. Do you think civil society has been strengthened by this crisis? Do you think the role of civil society has become stronger? And also, thinking about your experience in the past, you have had first-hand knowledge. Well, civil society at world level is not strengthening. It's not getting stronger. We should say that quite clearly. Lobbying, participation are not getting stronger, I can tell you that. But in health, in the context of these crises, I think it was very difficult at the beginning for civil societies, because with all these measures, public health measures, restrictions of movement, meeting, social distancing, they were justified measures, but they have prevented dynamic mobilization of people. But very quickly, people have organized in different ways. They've used the same technologies we're all using to express their opinion and to make their requests. And we have insisted a lot so that the response to COVID-19 listened to people. It's not been easy. It's not been easy because, of course, the international community went into crisis mode, command and control, and forward. But that's not always the way to do things. You need the confidence and trust of the people. You can't just ram things through. So as we move forward, I think that people's voice has once again been listened to, and I think that they have benefited from a political agenda that put health in the main position. But it hasn't been easy. Good. This first round, we're going to finish. I want you to tell us our perspective on ISGlobal. Antonio, we've been talking about infectious diseases, but we should look beyond those diseases. There are other systemic risks. We spoke about wars, volcanoes, occupational hazards and accidents. Could you, Tony, tell us how this has changed and what does ISGlobal think about all this? Well, thank you, Gonzalo. Thank you. Gracias a todos por estar aquí en representación de ISGlobal. Thank you to the Ramón Areces Foundation. Thank you to Gonzalo and Elizabeth, because they have been the true engines of all this. Many people at ISGlobal in the context of all this work. I think that one of the important aspects when we take a transverse look at all these risks is to realize where we're coming from or why what has happened. I haven't got the clear answer. I come from public health. I've had public responsibilities within public health. So I know a little bit about some of the biases, social biases that explain the situation we're in and what happened. And I would like to project this into the future and say, if we don't remember this, it's going to happen again, be it infectious diseases or whatever it is. Now, in the 90s, we were already talking. People were already, experts, scientists were already saying that the risks of infectious diseases were very significant and that we had to be ready in terms of vigilance, alertness, detection, prediction, scenario designing scenarios and responding. In the 90s, and this is the end of last century and the beginning of this century, there's been a disconnect between knowledge and what people have, what politicians have actually decided to do and what states have done. I'm talking in general terms, and there are three biases here that are tremendously important, and allow me to use a zoological simile. There's the simile of the black swan, a risk, a very low likelihood risk, perceived very low risk but very high impact. That's one thing. The perception, for instance, within infectious diseases of that situation has led to a situation where, for instance, people have not devoted time to something that has a very, 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 very low likelihood, but a very, very, very high impact. They've forgotten about those things. Then there's another bias. What is immediate? Thinking in the present. We in public health know that the paradigm of prevention and the value of looking into the future and prevention are key. And sometimes people forget about that because they're too involved in everyday business. They're involved in sorting out problems right now, right here, right now, acute illnesses, people that are ill right now. Prevention is a rhetoric which we're going to have to strengthen even further. And not just think about the here and now, we've got to think about tomorrow and the next day and the next day. And then there's another thing, which is two more effects. One is the effect of what is called the Grey Rhinoceros, which is the rhinoceros is charging at you and you don't see it. Remember the pictures from China? We saw pictures of a hospital where Chinese people were building a hospital in a matter of days, for a 1,000-bed hospital. And here in Europe, there's this rhinoceros charging at us, and people they ignored it socially, I mean. So this is another bias, another problem. We forget about what's coming at us and the systemic risks that, in health matters. And then there's the cry wolf thing, the cry wolf, and that's the last animal. We've had a swan, a rhinoceros, now we've got a wolf. Cry wolf, you know, the cry wolf effect. You cry wolf all the time, and when it came to influenza, Ebola, SARS, MERS, all these different crises, they were interpreted as significant, but at the end of the day, people said, oh, well, it wasn't that bad, was it? They keep on crying wolf, but it's not really important. Let's carry on with our business. So that's another big threat. And all this is important. If we don't bear all this in mind, I'm afraid that at administrative level, at the level of society, if we don't bear this in mind, there might be, we might repeat our mistakes in the future. So what I mean to say is that we've got to be fully aware of these lessons of the past, of the immediate past. And then if you ask me, I will answer what science has to say, or we believe has to say about this. But there are lessons that have clearly shown us how complex reality is. We are living in a world that is tremendously complex, diverse, and especially it's really accelerated, and the responses can't be conventional responses. There's got to be a lot of interdependency because there's a huge level of vulnerability, and it's not consistent throughout society. One of the analyses that we have to implement is that of impact on inequality, the impact of inequality, the impact in different regions, the impact of poverty, etc. So, thank you, Tony. Well, I see we've only got 14 minutes, but they've forgotten to put that back to 0, that screen. I'm going to change, however, gears because we're running out of time. And I remember Galileo's Walker once at a meeting, somebody was speaking and went on and on and on and on, and he took me by the arm and he said, "What right has this gentleman have to bore us to death?" I don't want to bore you to death. So, I'm going to put things together and ask you for very, very synthesized and brief answers. I'm going to start with you, Rachel. I'm a fan of Mariano Mazzucato and his concept of entrepreneur states. We have learned that states are key to transform science and knowledge. And I want to ask you now, what state do you dream of? What public administration would be ideal in the context of all these things?
I'm also a fan, and I think it's a concept that is, when you include it in the policies, is a transforming element. We talk about fragmentation in many different settings, biases, and here possibly we've had a conceptual mistake for a long time. The defense of public interest what had to happen was through establishing a compartmentalization between the private and public entities, when in reality what should be is that from the public setting, we have to do that the private environment could participate in order to generate public interest. And this is a change of paradigm. The state has the commitment of involving all the stakeholders. And in that involvement of stakeholders for a specific goal, the leadership have to be achieved from the public setting with specific tools, not with ideas, but with tools that allow not only at the time of the response, we talk about innovation, we talk about the supply chains of making the ideas that are generating into products, but also in this environment of preparedness, in this focusing on the more flexible part where all the stakeholders have to be involved, always with the concept in mind of the fair return of transparency as well. And there we have learned a lot. Many barriers have been disappearing. And we've seen there are things that we could do with the companies that create value as well for the academic setting, and also driven from the public sector, not only with financing instrument, but also with coordination elements. Sometimes what fails in that public-private collaboration that we talk so much about are not the incentive from the public setting, but as well, but also collaboration structures that arise from trust. And we talk about what is private, and there we think about productive tissue, but then that also the private initiative that Anya, who represent this in a very excellent manner, the initiative, that not only is private financing, but also visibilization. We talk about entities as ISGlobal that are born from the public-private collaboration, and that do show with their excellence that there are a success model, and how from the institution we can incorporate and multiply and establish value chains. Well, it's a commitment that I hope I haven't exceeded my time. We are being mad without any chronometer.
Bernard, let me continue with this. Where do we get the science that we need, and how we fund it? I want to give you the opportunity to talk about one of the ideas that we are considering of collaboration, because it's different. This is coming from a different place, the kind of knowledge that we need, and I think that the public sector or the public interest, understood in a broader sense, can play a fundamental role in this regard, no?
Okay, maybe I will start with a general comment. Recently, the Independent Panel for Pandemic Preparedness and Response tried to call for a model where innovation is left, changing the model from a model where innovation is left to a market to a model aimed at delivering global public goods. Right. I think for me it's a framework that we need to have in mind. And for this, of course, it's necessary to agree on norms and binding rules that will change this framework. It's necessary to have a better global leadership and better governance and better structure balance of the responsibility. But and under the coordination of WHO, because I'm a strong supporter that WHO to coordinate, we need new initiatives that prepare this response on a sustainable way. So it's exactly what we have presented yesterday in a workshop my colleague presented. So lesson learned from our experience of anti-COVID in Africa, we think that it's time to prepare during the peace period, the inter-crisis period, to prepare the field for innovation. So, of course, with investment on one side and investment connected with some norms and restriction to be sure that the new product will be equitable and equitably distributed at the end. But for the conduct of research activity, particularly in low-emitting countries, we need to have something in place in advance. So we propose with partners a new network for clinical study called PANTER, where we aim to have already in place some capacities in different countries, some hubs, being able to develop capacity of research, to have a protocol being defined in advance, to try to overcome the regulatory and ethical difficulties, because we have not mentioned this until now, but it has been a nightmare to put in place research in many places. Maybe UK was the exception during this period, but the rest of the world was confronted to this example. So we promote this from now. And this requires, of course, some investments. This requires some engagement from the country, from the political leaders. Right. It's why this will be successful if we have in Africa, if we have African leaders ready to commit.
This is happening in Africa.
The aim is to start with a solid network in Africa, but with connection with the rest of the world, because we have learned from the pandemic. We need to adapt the response to the magnitude of the problem.
Thank you, Bernard. Let's continue talking about that sustainability, Anya, the architecture that we need. No, as I said before, when you work in development, there is no area that has changed more than global health in the last couple of decades in terms of building the kind of architecture which is completely new. What is it that we need, Anya? Do we have what we need? Do we need to invent a new organization, a new global fund for preparedness, or do we have what we need with the kind of institutions that are being presented here?
Yeah, I mean, I think we have largely what we need. I think it is a coordination question, and as we were trying to describe it earlier on, I think there is definitely the need to invest in health system strengthening and with the focus on primary health care, because I think as we've seen from this pandemic, any pathogen that has the ability to actually develop into a pandemic, is very much linked to, endemic diseases such as the Global Fund is addressing. And, and this goes back to with an interdependence, and it's interlinked to an actual sustainable, resilient, well-functioning health system. So I think here addressing this on a country level both and from a donor level with regards to multilateral organizations that are very active in that field, I think is very important. So I think that this is the one cornerstone that we need to improve, and we need to keep working and pushing both on the country level and from donor funding perspective. I think secondly, what we talked about is the surveillance and the tracking. I think we have the mortality tracking, we have the genomic sequencing, we have and here the coordination element is incredibly important, such as same thing like for R&D, that this is actually, and there are many ideas how to improve that. So I think the general idea is there, but again, you can build on it. The other piece is on the R&D and on the financing, which is how do we bring these two things together. We've heard that on the R&D side, you need to be able to have actually search funding. I think what we need are two things. One is sustainable funding into therapeutics, diagnostics, and new vaccines. There's, of course, the idea, the platform technology idea, but also these sort of broadband vaccines that are much wider than just the specific diseases. I think the whole mRNA technology, this has so many prospects, how it can be improved now and adapted and faster, and that we get even faster to the development of vaccine prototypes. We know where money needs to be deployed, and so I think what we need from the donor side, together with the private sector, to ensure that. And the last thing I say is that what may be new is sort of, the deployment of such a specific task force, the global endemic sort of response team, or however we title or label it in the end. But I think this is the one where, as almost like an executive arm of a global health architecture, that could be deployed, but with a very, very key that it needs to be embedded in the national coordination systems. They need to be in country. They need to work really closely with the affected countries. That's the key part here.
Thank you very much, Anya. François, el fondo ha sido...
Well, the fund has been very driving in the structures that have been created on the fly, as the FTA the accelerator for the generator of diagnosis, treatments, and vaccines in the case of COVID. How much of all this should we maintain? Is this helpful? Can we extend it to other systemic risks? That creativity that we have shown, how can we maintain it? Yes, thank you. It has been a great effort to create this Accelerator Act, both to accelerate the development and the fair distribution of the tools to fight against COVID. And the interesting thing of this mechanism is that it's built on an ecosystem. Instead of saying we're going to create a new organization, then we will spend 2 years discussing how we coordinate, and among the coordinations, it has been look at the global ecosystem with everybody being involved to guarantee that we are covering the response from A to Z with all the tools and all the dimensions that we should join our efforts to tackle. And I think this is a lesson learned that is very important to optimize the strengths of the ecosystem of the organizations that already exist before considering what can we create as a new thing. Maybe we have to construct something, build something new, but not before having analyzed completely and exhausted the possibilities that the different mechanisms and members and partners that exist can evolve and better coordinate. And I think that under the circumstances that we are in, we have reached quite good results with that mechanism of coordination. Among the challenges, the issue of equity has not been as rapid and efficient. The issue of participation of the communities and the civil society has taken a long time. There are many things that we need to improve. But I believe that it's a good experience. And in fact, I wanted to mention that the G20, in its joint analysis of the famous task force, Health and Finance, have analyzed that several organizations, including the World Fund, the WHO, and others, are fundamental pillars of the preparedness for future pandemics, due to the same capacity that we'd have of mobilizing ourselves, but also to work together with the focus on the national plans, as has been mentioned today. And I go now over to the European perspective. This is, in many things, we have advanced very rapidly in integration of some of the responses, and we need to advance even more rapidly. Do we need to go more rapidly? Do we have what we need as a regional architecture already? Microphone, please. Microphone. She's not using the microphone. I'm sorry. We can't hear. She's not using the microphone. The legislative possibility of acting. But I believe that the new regulations that are ongoing will allow us to make that leap, qualitative leap, in the financing of the health program. Will also be able to locate us in the international sphere. We have talked about the pandemic treaty, and the European Union is acting again as one single voice and 17 votes. This is what we always say. And then we also have an advantage that not only is well known or recognized by the others. When we talk with different organizations, for instance, the WHO, it's a purely health organization. The advantage is that the European and European Commission say it's that it's a multi. We don't act only in the realm of health, but in everything. And this has a multiplying effect. And this allows us not having to say, I will tell my colleagues in other international bodies to see if we can. This is our daily task. We have what we need, more or less, but we still need something more. The member states seem to face this in a different manner than they did before. Well, yes, we had advanced quite a bit, but since the purchase of the vaccines, you know that better. But I'm going to ask another question, even more complicated, from Juan Fernando. Autonomous communities and the municipalities or town halls have a centralized health system. We saw that yesterday. It's only efficient if it guarantees a coordination of the administrations at all the different levels in a very synthetic manner. But are you optimistic at this respect, or do you think we have advanced, or are we going to struggle and fight with each other in the future? I'm very optimistic because I've been doing this since 20 years. The ministry has no direct competences for management, and we are always in the middle. And to be in the middle has good things and bad things as well. What have we done in this time in order to be more optimistic? We have created, I'm going to focus on my side, we have created a General Secretary of Health. We need to connect the data, and it is not as simple. When we set up the Share Lab system, where you collect all the data of a COVID test, there are only 3 possible ones: positive, negative, or not conclusive. 47 different forms in our health ecosystem to say that. Although we speak the same language, we are very hopeful with the new regulations of data, governance of data, and the health space of the data in health. We are working in order to achieve that through PERT, the PERT of health in the vanguard, with a clear focus that tries to prevent the biases that we talked before. In primary care, because we are going to make a new surveillance system that is going to have an important focus on the part concerning the transmissible diseases, but the great forgotten ones are the non-transmissible ones that we die more than from the transmissible ones, and that generate a greater inequity. This is our approach. Perfect.
Let me ask you the same question, Oliver and Wesham. Is the question that I did, but the other way around. This is not about how to support the science, but how can the science support what states, what private and public institutions can do. How do you see the role of science in this regard and to engage with practitioners in this? Oliver, if you want to start, and then Wesham.
Sure, thanks. I think it's clear that the public sector does not have the capacity and probably shouldn't have the capacity to do all of the research that's needed in the world. And so the public sector has to work with the academic sector and the private sector. I think that's absolutely clear. The other thing, there's huge investments that are happening. I think Isabel mentioned the investments from the European Commission, and there are many others which are vitally important to move us forward. But at the same time, we must think about the absorptive capacity of our public sector to make use of that research, which is a really specific thing, and research output doesn't always automatically translate into either public policy or public sector intervention. I think the third area, which is important and very specific maybe to the public health surveillance area, is that we need to include input from other sectors. And Bernard and Françoise spoke about the importance of equity. Well, we can only make progress on equity if we measure inequity. And sometimes that measurement needs to come from sectors that are not public sector. And I think during the pandemic, we saw some really interesting and exciting innovations, even something straightforward, relatively straightforward, such as the Johns Hopkins work, which is an academic institution doing global surveillance, was fantastic. Our World in Data was another example of great work done by non-public sector. But I spent a lot of my 2 years responding to member states who are asking me why they were presenting data that was different from what the member state was saying. So from a public sector, there's a role of official statistics, but the public sector needs to embrace other types of information coming from other areas, and that's really challenging.
Thank you, Oliver. Wesham, please.
I think in the mission of Africa CDC is mainly strengthening public health institution capacities and capabilities in order to be able to respond effectively and efficiently to different public health emergency. And at the end of this statement for the mission of Africa CDC, it's focusing mainly that this solution that we're offering should be evidence-based and scientific-based. And this is when it's very important to collaborate with different research centers in order to ensure that the solution that we're offering to the member state should be led by science, it's evidence-based. So I think this is very critical. And we're trying to strengthen lots of capacity based on this evidence and research that we're doing. Strengthening surveillance system, to enable the country for early detection, like event-based surveillance, and also the importance of pathogen genomic sequencing as well, and doing this kind of detailed analysis and following the different variants that will enable member states, once they pick change in the variants, they notify quickly and able to respond efficiently. And here is success stories. When we start investing in pathogen genomic sequencing, let me tell you, for the first year in Africa, the continent did only 5,200 genome sequencing for the first year of the pandemic. 1 year later, we moved from 5,000 to 60,000. In the first quarter for this year, we did 30,000 only in the first quarter. So investment in this kind of research capacities and having this resource available to the member state, this is the key for us in the future to face the pandemic.
And I finish with you. I would like you, I wouldn't, well, but I would like you to tell us that viewpoint from a particular interesting aspect, that link between science and translation and the contribution that can be done, given to this architecture that we talk about. Thank you. In order to put into context, give the background of what we have well said, and ISGlobal is slightly less difficult to explain, and in that respect, the pandemic has helped that all health is global. And all health is global, and that's exactly how it is. And this means that the countries, the communities have to have a strategy, health strategy that is global. This is explained, it's more difficult to explain from this fragmentation, this domestic vision of in the inside borders of the health systems and governance at large. So science plays a fundamental role, or has played a fundamental role, that's obvious. There has been an acceleration that has been very important, and the society and their representatives have understood that science has contributed with solutions that, of course, have not been developed just in a few months from the pandemic, but long before there have been investments, sometimes not necessarily too well supported, but that have been made the possibility of finding solutions that have been game changers. So the social legitimacy of science has increased in general, and there I think we have two challenges ahead of us. And two challenges. One, strengthening the collaboration spaces between knowledge and the decision-making without separating the thinkers and doers. This is not what I'm saying, but also greater interaction and strengthening, identifying and reinforce the good practices of interaction between the public decision-making settings and knowledge in an ultra-rapid setting and growingly complex as well. And the other one is the interaction with the population. We've talked about trust. It's a fundamental element that science has to contribute to in spite of sometimes of understanding what is uncertainty and the changing knowledge and responding sometimes not immediately to the expectations of a miracle from the population. The third one is financing. Research functions via financing. ISGlobal works. We have a budget, 80% of which these are competitive funds, 80% of which are international funds. So our challenge there is not only to guarantee excellence in the big leagues, but also participate as a Spanish institution and that is contributing to these capacities and wants to contribute actively. And to come to the end, what does it mean to contribute? And this is what we practice on a daily basis. The first thing is that obviously knowledge is a fundamental tool, but as has been said, the knowledge is not transforming by itself. It needs to strengthen those interactions. It needs to establish a dialogue from the rationale of the public decisions, of the public systems, of the society at large. And this is quite complex, but in ISGlobal, we make great efforts in order to guarantee this. And finally, you have said finally 3 times. I will listen to you. It was finally 1, 2, and now finally 3. That is to serving from knowledge and translation, this vocation that I said that represents or rather has the support of heads of different institutions, including from the Spanish government, and we thank them for that. To be an intermediating institution, the example today is an example. To be intermediator, not mediating, but it's able to attract and promote conversations, but also decisions of different partners. Not improbable, this is a word that you like, I know, but at any rate, that is not quite obvious that they speak together and work together, and somehow they can contribute in an aligned way to the future. Thank you, thank you.
Well, good, that's it. 2:05, we're late. We've complied with the 2 hours. I want to thank the panelists. I'm sorry it was a bit rushed, but our aim was to listen to each other and put together a group which not always has the opportunity of talking together in a context like the Spanish context, and promote a conversation within Spain that we think is key. Thank you very much for your patience, your generosity. Thank you to the audience here in the room, the online audience. A million thanks to the Ramón Areces Foundation. They're always warm in their welcome. They've always supported us. It's a pleasure working here. And finally, thank you to the ISGlobal team, which has worked so hard for so many weeks to make this possible. Thank you very much. I hope and expect that this conversation continues in the future, and we are going to make sure that that is the case. And I hope to see you soon. Thank you.